Welcome to the BLSGroundCrew podcast. Before we dive into today's topic, a quick disclaimer. While I am a certified advanced EMT, I am not a physician. The content in this episode is for educational purposes only and should never be taken as direct medical advice. The views expressed in this podcast do not reflect the views of my employers and are my opinions only. Always refer to your local medical direction and protocols. Hey everybody, welcome back to this week's episode of the BLSGroundCrew podcast. This week we're talking about communications and documentation. These are two critical points in healthcare and especially in pre-hospital healthcare. First, let's talk about therapeutic communication. The way that we talk to our patients is critical, and it changes based on certain dynamics. Like when we're talking to a patient who's in a lot of distress, we are going to want to try to use therapeutic communication to calm them down and to assist them with feeling comfortable with the situation. There's a lot of different techniques to therapeutic communication. We always want to address our patients in a way that makes them feel safe and makes them feel comfortable. It's important that they understand that we're there to help them, that we want to do whatever's best for them. Now, with patients who are acting up or who are having behavioral issues, we might need to use a more stern tone of voice. But the way that we use our voice directs that scene and directs that communication with the patient. We also want to talk about nonverbal communication because the way that we use our bodies and the way that we communicate nonverbally with patients also affects how the scene flows. If we show up with a panicked look on our face, the patient feels like we're panicked because we're rushing and our hands are shaking and we're not quite sure of what we're doing. That's going to make our patient feel uncomfortable with us as a provider, even if our communication, our verbal communication is on point. Our nonverbal communication is just as effective as our verbal communication is when we use it the right way. The way that we sit, the way that we stand, if we show up with our arms folded versus our arms out, really affects the way that the patient feels about us. Effective nonverbal communication requires that we're paying attention to how our body posture is and how we are signaling and what we're doing with our hands and with our eyes and with our body. It really depends and changes the tone that we're setting in our communication with that patient, just as much as how our voice is being used changes how we communicate with that patient. Let's talk about special communication techniques. Different types of groups require different special communication techniques. With children, it's really important that we get down on their level and talk to them in a way that they understand. I wouldn't show up to a pediatric patient and say, "It appears that you're in status asthmaticus. We need to give you a nebulized bronchodilator right away." That wouldn't make any sense to them, and that would make them confused, disoriented, and possibly even frustrated. With geriatric patients, these are patients that are elderly. They may have a difficult time hearing, and it's important that we find the best way to help them hear us and see us. One of the techniques that they often use to cope with their inability to hear is lip reading. So it's important that we're making sure that we're facing them and that they can see our lips when we're talking to them. Also, if they're unable to understand what we're saying, it might be important to write down what we're trying to tell them on a piece of paper. That would be a nonverbal communication technique that we would use with this special patient population. Hard of hearing also kind of falls into the geriatrics, but it's important that we don't assume that everybody has great hearing. We can start off the call talking to them, but it's important that we make sure that they're understanding what we're saying. And if they don't understand what we're saying, then we need to communicate with them differently. Visually impaired patients can also have a difficult time understanding what's going on. We may have to talk to them about where we're going to be placing an IV or helping them find medications to take, such as aspirin or nitroglycerin. We may need to use different tools to help them see what's going on or help them understand what we're doing. It's important that we announce our presence when we enter a room with visually impaired patients so that they can understand who's in the room with them. Non-English speaking patients. This one is really prevalent in my area and it actually becomes quite difficult. We do have a little medical dictionary that's like 5 or 6 pages long that we look at to try to translate, but I'll be totally honest, I don't know very much Spanish at all, and it's something that I want to learn more about and improve so that I can communicate with non-English speaking patients, Spanish-speaking patients in my area. It's important that patients who speak any language get the same level of medical care. Now, sometimes this just means that we have to make a phone call to one of their family members who does speak English and they can help translate for us, but that does delay the call quite a bit. Let's talk about effective transfer of care reports. When we're transferring care from our ambulance to the hospital, it's important that we communicate with them what's going on. And we need to be able to do this in an organized, timely, concise, but also accurate fashion. Most providers use the DMIST acronym to remember what they need to communicate with the hospital. D for demographics, M for mechanism of injury or medical ailment, I for injuries or illness, S for vital signs, and T for time of arrival. This helps us to let the hospital know what they should expect from us and when we'll be there, and the current condition of the patient, and the vital signs, and who the patient is, if this is a 78-year-old male or a 6-year-old female. It helps us convey to them information they need to get started and prepared for care. Let's talk about communications equipment. This is almost definitely something that you'll see on your National Registry exam. So this is a portable radio. Portable radios are handheld and they typically have an antenna and a body. We also have mobile radios. Mobile radios are radios that are vehicle mounted. This would include ambulance mounted radio or a fire truck mounted radio or a police vehicle mounted radio. We also have base station radios. Base station radios are building mounted radios. These would be radios that are placed in fire stations, police departments, or for dispatchers at dispatch centers. And then finally, we have repeater-based radios. Repeater-based radios or tower-mounted radios are typically placed high up on a hill or very high up on a tower. When they receive an incoming signal on one frequency, they turn around and transmit that same signal on a separate frequency so that more people can hear what's going on from this really high mountain, hill, or radio tower. Let's talk about enhanced 911. So enhanced 911 is one of the things that's come out within the last 10 to 15 years that's really helped dispatchers and all first responders. Enhanced 911 allows the ability of the dispatcher to see where the call is coming from, particularly if the patient is using a cell phone, they can see the exact GPS coordinates of that cell phone. And if it's a landline phone, they can see the address. It also provides them with phone number information so that they can call the person who's calling them back if they need to. These calls are answered at what are called PSAPs, or public safety answering points. PSAPs are typically dispatch centers, but not always. Let's talk about the different phases of an ambulance call. There's several different phases. They start with dispatch. Dispatch is when somebody calls 911 or the non-emergency line of the dispatch center and they get a call taker. That call taker takes down their information and dispatches an ambulance, which is when our pagers or station alerting devices go off. After our station alerting devices go off, we go to the ambulance and we let dispatch know that we are accepting the call. After we accept the call, the ambulance goes en route. When we go en route to the call, we're driving to the place where the call is at. Then we arrive at the call. After we arrive at the call, we are on scene of the call. And that means that we're there and we're locating the patient. Then on-scene care happens. This is part of the on-scene phase. And then transport happens. Transport and transport care happen when the patient is in the back of the ambulance moving towards the hospital. Then we have transfer of care. This is when we transfer the patient to a hospital level provider, an RN or a doctor. Then we go back in service. After we get everything cleaned up on the ambulance and totally restocked, we go back in service and we're ready for the next call. Those are the phases of an ambulance call. Let's talk about written communication. The main form of written communication that we have is something that we typically do on an iPad, like this one, or a tablet device or a computer. And what we're doing is we're charting for the patient. That's EHR, which is an electronic health record, or a PCR, a patient care report. In those charts, you would find what happened on the call, who was on the call, where the call was, what time the call happened at, the types of things that were provided to the patient, where the patient was taken to, what the patient's condition was, the signs and symptoms that we saw. Those kinds of things would all be contained in a patient care report or an electronic health record. The government agency that determines what type of information is required in a patient care report is NEMSIS. NEMSIS determines what information is required, and that changes from year to year. This is one question that you'll frequently see on the NREMT. If you make a mistake on a chart, you have to cross that mistake out with a single line and then initial below that mistake, and then note the correction next to or below where you crossed out that mistake. Most agencies have gone to an electronic health record, which means that that record is stored electronically. In that case, you would just hit backspace and correct the report. Refusal of care reporting. Refusal of care is one of the things that is most likely to get you into a lawsuit. It's very, very important that we document everything about refusal of care, that we are talking to the patient about the concerns we have with them not going to the hospital, why we recommend them be transported to a hospital by ambulance, what hospital we recommend they be transported to, and then we'll also document that they did not want to go with us and that we let them know that they could call us back at any time, and if things get worse, they're welcome to call us back, and the risks associated with not going to the hospital by ambulance. Finally, we'll talk about reporting abuse. In almost every state, EMTs and advanced EMTs are considered mandatory reporters. This means that we must report things like child abuse, elder abuse, sexual abuse, violent crimes. Those kinds of things must be reported. And it's very, very important that we document those things in our electronic health records, and that we document that we reported those things and who we reported them to. Thank you for listening to this week's episode of the BLS Ground Crew podcast. If you found value in today's discussion, please like, share, and subscribe. For all of our audio listeners, please leave us a review. It takes only a few seconds and helps spread this valuable EMS content. If you'd like to see early releases and exclusive episodes, join our Patreon or become a member of our YouTube channel. Thanks. We'll see you next week.